A very warm welcome to the 10th IAOCI World Congress in Las Vegas. Unfortunately, the current circumstances don't allow me to travel to the US. That's why I present to you virtually. But I still hope I can transfer the spirit from Switzerland to you, and I hope that my lecture is very interesting for you. My name is Dr. Rebekka Hueber. I'm an oral surgeon and a specialist in biological dentistry and ceramic implants at the Swiss Biohealth Clinic in Kreuzlingen, Switzerland. That was founded by Dr. Ulrich Wolz, who has placed more than 25,000 ceramic implants in his life. And we are working a lot with biological augmentation, with augmentation in combination with ceramic implants, and we have a lot of new techniques that I want to present to you today. So my topic is the guided augmentation procedures that we build up for you to have an indication-based augmentation process. Because we have to rethink augmentation and biological augmentation when it comes to ceramic implants. And we have some tools that help us to build bone in a biological way, and not to have techniques that help us to decide which bone graft we need according to the indication that we face on our patient. When it comes to ceramic implants, we have a really long experience. This is a picture or an X-ray of ceramic implants that were placed by Dr. Ulrich Wolz back in 2001, so 20 years. These implants are 20 years in the patient, and it was a patient that even back then didn't want to have titanium implants. That's why he placed these ceramic implants, and where his love and his passion for ceramic implants really started, because he saw that the gum is forming the zirconia epithelial connection with ceramics and is actually closing around the implant. That's something we don't see at titanium. A tissue will never grow on titanium, but it forms a stable and strong connection with zirconia. And that is really important for the immune system and the systemic health of our patients, because we don't want to have an open door at the gum, like a leaky gum. We want to have a closed door where no bacteria can infiltrate. And in addition to that, with ceramic implants, we have really nice aesthetic results that you can see here. And this is a picture many years later, in 2011, 10 years later. There is no change of the bone. And that proves that when ceramic implants are healed in, we don't face any bone loss anymore. We don't face peri-implantitis on these implants. This is a picture of the implants 20 years later. And you see on the middle tooth there was a loss of a little bit of gum, but this can be corrected when you remove the crown and prep the margin of the implant on the margin of the gum. So it is not really a big problem with ceramic implants, and it is due to the hygiene of the patient that was not really having a good oral hygiene in that time. But still, when we look at the X-ray of 2019, we see that the bone level around these implants has not changed at all. And here you see the date when the X-ray was done. So we have a lot of experience, and it is now time to prove that. And when we look into the scientific literature, we find a lot of studies about ceramic implants. And a lot of studies show that the ceramic implants show an equal or even better healing behavior compared to titanium implants. Not only that, they're a proven alternative to titanium implants. And the whole team of the Swiss Biohealth Clinic took a big effort and collected all scientific reviews, all studies that we could find about ceramic implants, and there are studies that are over 20 years old. And we collected them in a book, The Current Scientific Status, and that book has over 80 pages of studies about ceramic implants. So if you ever want to have that, contact us or contact for example, Swiss Dental Solutions, and you can get all these studies and dig deep into it. And it shows that we are not working out of the scientific world, but the scientific research is already there. And we're adding more and more to it. But what you need to know, and what is really important when it comes to ceramic implants, is that they're easier to handle, but they are different. So if you have your titanium brain, you really have to think new and think different. And that is the shift that everybody who changes from titanium implants to ceramic implants has to make in the head and has to learn about it, because it's a total different material. It behaves different, but it's easier. We can do a lot more. We need a lot less bone graft, but you need to know about the whole material and how it reacts and interacts with the bone and with the gum. When it comes to bone graft and bone augmentation, it always helps to classify our bone defects. What we have in Europe, and Germany, Switzerland, is the CCRAD, the Cologne Classification of Alveolar Ridge Defects. It was found in the 8th European Consensus Conference in February 2013, and it's still the current classification that is recommended in the scientific world. And that is something that has to be changed, because when it comes to ceramic implants, we have a lot other therapies, and we have to rethink bone grafting. But still, the classification is really interesting to take a look at. It is divided into 3 parts. So part 1 would be the orientation of the defect. So we classify in horizontal defects, vertical, combined, and sinus defects. Then part 2 is the reconstruction that is needed associated with the defect. So do we have a low defect of less than 4 millimeter of bone resorption? Do we have a medium defect of 4 to 8 millimeter of bone resorption, or a high, big defect of bone resorption of over 8 millimeter? And then what is really also important to look at is part 3, how is the relation of the augmentation and the defect region? And here we divide into an internal defect that is inside the contour of the alveolar ridge, or an external defect that is outside the ridge contour. And that makes a huge difference. What is very interesting in this CCRD is to look at the therapy recommendations. And here we see that we really have to develop new recommendations, because, for example, the iliac crest block and chip is recommended on a vertical defect of less than 4 millimeter, which would be a low-grade defect. We all know that iliac crest reconstruction has a lot of side effects. It is a risky intervention, and we also have a high resorption of the bone. And I think it is definitely not recommended in a vertical defect of less than 4 millimeters, especially when we work with ceramic implants. Other techniques that are recommended is the distraction osteogenesis or the sandwich technique, but that are also techniques that are not state-of-the-art anymore. We have a lot better techniques, and especially when it comes to ceramic implants, easier procedures, and procedures that we can immediately combine with the implant. So we don't have to first build up our bone and then place the implant like we used to with titanium, where we really need a lot of bone around our implant before we place it. I will show you that with ceramic implants, you need less bone, and you can combine it. You can combine your bone graft with ceramic implants very much easier than with titanium implants. So it is the time to rethink these therapies and these recommendations. I tried to show you the classification because I still think it's interesting in pictures. So a horizontal defect of 1 to 4 millimeter would look like this. Here we have a horizontal defect of 4 to 8 millimeter and more than 8 millimeters. When you have a vertical defect of 1 to 4 millimeter, you see the first pictures, it's just a little bit of bone loss, middle bone loss, and the lowest picture is over 8 millimeter bone loss. And more than often, we also face a combination of these defects. So it's a combination of a horizontal and vertical defect. So that would look like this for 1 to 4 millimeter, for 4 to 8 millimeter, and over 8 millimeter, which are huge defects. And for every defect, in the following, I want to show you how you can build them up with ceramic implants or other tools. We have a whole education program about this in Switzerland. It is called the Bone Augmentation Week, where we really very compact show our participants all the different techniques with the ceramic implants, because at the Swiss Biohealth Clinic we have a very, very high experience with this, and we want to transfer this knowledge to you and make it easier for you in the dental office to handle these bone defects. When we come to the alveolar ridge, you see the red line shows a defect that is within the contour of the alveolar ridge. That means we still have sidewalls of the bone, or for example, we have the teeth. And the importance in this is that we don't have any pressure of the tissue on these defects, and that makes bone graft much easier. It is more difficult when we have an outside the contour defect, because then we have a pressure of the tissue, of the cheek, of the vestibulum, and we have to form a shield in front of our defect in order to keep this pressure away, because pressure on our bone graft will always initiate a bone resorption, and then we lose our bone graft. What I miss in these therapies of the CCRD is definitely ceramic implants. It is also the titanium mesh, for example. The titanium mesh is a proven alternative or a proven technique for bone grafts, and I will show you a special technique for titanium meshes in the following. And I miss the open healing concept. And the open healing concept is a paradigm shift in bone grafting, in bone augmentation. I will explain to you in a while what it is. And we use it a lot at the Swiss Biohealth Clinic, and for me it is the future in bone grafting. So when you place a lot of titanium implants and you start placing ceramic implants, it's like you walk through a door and you let an old life behind you. It is difficult, in my opinion, and I see it often with colleagues, to go back to the old life. It is a totally new universe that opens up for you, and it is important that you don't think in old ways. It is modern dentistry, and we have to rethink a lot of techniques and a lot of therapies that we did in the past, because it is a whole new paradigm shift that we are facing at the moment. And we can't close our eyes anymore, because patients are asking more and more. We have the biological benefits of this neutral material for our patients. So it is important to educate yourself in ceramic implants and also use them. And we work really closely together with Professor Dr. Shahram Ghanati from the University of Frankfurt. He's a maxillofacial surgeon. He's the world-renowned researcher for biomaterials, for plasma-rich growth factors, for PRGF, for PRF. He's doing surgery on a daily basis himself, big tumor reconstructions, big face reconstructions, and he works a lot with PRF and also with ceramic implants. And he also helps us to bring the whole topic to the scientific world. And it is really, if you ever can hear a lecture from him, I really recommend to listen to it, because his knowledge about bone and soft tissue behavior is incredible, and you can learn a lot of it. And he works closely together with Dr. Ulrich Wolz, who has the most experience in ceramic implants, since he's placing them over 20 years and has placed over 20,000 in his life, and never stopped to develop the implants and develop the whole system and make it better and better. And together with the team of the Swiss Biohealth Clinic, on a daily basis on our patients, we work with these techniques. we really use them and we have high success with it. That's why we have a lot of patients where we need to do huge bone grafts, huge biological bone grafts, also with ceramic implants. And here you see me doing a live surgery on a bone augmentation week. So on this week we also have live surgeries. We show live on patients how these techniques work with several cameras and with several surgeries on the same time, so that it is never boring. And together as a team we develop these techniques and bring them into the world. And all these techniques are in our guided augmentation procedures book that we are constantly developing and that everybody who comes to the Bone Augmentation Week gets, where we have all the techniques and all the new techniques for ceramic implants in one book, so that you can always read them and have a look. Ceramic implants need to be in a special shape, in a biological implant shape, and I will show you why. So when we come back to our classification and we see the first row of a horizontal, vertical and combined defect of 1 to 4 millimeter, these would all be defects that you can solve just with ceramic implants. Immediate implant placement and late implant placement. And also a defect of 4 to 8 millimeter, a horizontal defect can be solved within a ceramic implant alone, and PRF, for example. And of course, the defect must be in the contour of the alveolar ridge. And why is that possible? It is possible because of the lack of ductility that ceramic implants have. What does that mean? Titanium implants have a lot of ductility. You see that when you sit in the plane and you look at the wings and the wings move. You want to have them move. When you're in the air, they move because the whole plane needs to be aerodynamic. A plane would never fly with zirconia wings because zirconia is not ductile, so it is strong and hard, and it does not move in itself. That is really important, and that is a benefit for our bone, because when you place a titanium implant and you have a thin alveolar ridge, for example, you need to reduce that alveolar ridge because you want to have 1 millimeter around your titanium implant of bone. If you don't have it and you have the tooth contact and the movement of the titanium implant, it will move and the bone will resorb. So we need a strong bone around our titanium implants. That is a pity because we will always lose bone. Yeah, and we always have to place bone level implants, and we have to use high abutments and long crowns, and we will have not the nicest aesthetic result maybe, and we have a gap always on the bone level, and that is again an entrance for bacteria. With ceramic implants, you don't have to reduce that bone. You can have thin bone lamella on the implant, because the implant itself, also with tooth contact, it will never move. So you will not face a bone resorption around your ceramic implant. And that means even if we have a bone resorption and a very thin alveolar ridge, we don't need to do bone graft around our ceramic implants. We can have really thin lamellas. And I show you a clinical example. And the good thing is we can place the ceramic implants on the position where we want to have it for the prosthetics and not where our bone is. And that's what you have to rethink when you use ceramics. You always place your implants where you want to have it for the perfect prosthetic result and not where the bone is. So, for example, on this example of a patient, we have a re-entry. You see, the patient had a horizontal resorption of the alveolar ridge, and you see that the implants were placed where they should be with a tissue level, but we see the microthread is not totally in the bone. And with ceramic implants, it is no problem, because either the way the tissue will grow on the implants and will close this gap, or sometimes when you have the right shape of the implants and you can you put a PRF around the implant and you have a wide tulip and close your tissue over that tulip, you create a hollow space underneath your gum, and the bone can grow in this area. And here you see the re-entry of these implants and how the bone really grew on these implants. So it's like a bone growing implant when you use zirconia. That means you need a lot less bone graft. And what is always recommended with ceramic implants is to do immediate implant placement. Here we see an example of a canine that was extracted. And what is really important when you extract a canine, for example, that you always stay in the palatal area with your implant, that you don't put the implant too wide, too far outside, because then you may face a resorption. So you want to have a hollow space in front of your implant for the bone to grow. And here you see a biological bone drilling. It is important to open the alveolar ridge on the crestal part so that you don't have any pressure of the implant on the crestal part, and that you have the most stability on the apical part of your implant. So the primary stability of your implant should always be gained on the apical part, because there, even if you put pressure on the bone, you don't stop the angiogenesis of the bone. It is because the bone has different layers, and compact bone does not have such a good angiogenesis. So on the upper part, on the crestal part, you never want to put pressure, because you will stop the angiogenesis, you will not have any blood flow, and then you will have a resorption around your implant. So whenever you can, it is really recommended to have a good implant with a good apical micro thread that helps you to gain stability on the apical part, and then immediately place your implant in the right position. With that procedure, you don't lose any bone in the healing. You have a guidance of your implant for the bone to grow, and you have a perfect aesthetic result also of the gum. So when we look at the defect of 4 to 8 millimeter, for example, the sinus, we have to use the technique of the internal sinus lift. And the internal sinus lift is a very important procedure that always should be combined with ceramic implants in the sinus when we have enough bone. I use special osteotomes for it that resemble the diameter of the implant and the length of the implant. And with these osteotomes, I can condense the bone on the apical part, and I can lift up the sinus floor and gain stability again on the apical part of my implant. Here we see an animation of how it's done. So basically, with an internal sinus lift, you push up the sinus floor, you create a hollow space in the sinus underneath the Schneiderian membrane, and then you can place your implant and gain stability on the apical part. I have a video for you, a clinical video. Here you see on the upper right, you see a premolar and a molar that need to be extracted because they were inflamed, and the patient had a lot of pain with them. And you see that the root is only 6.5 millimeter. With ceramic implants, you should always place longer implants. That's due to the material. So you want to place an 11 millimeter implant, for example. So it is no problem and very easy to push up the sinus floor around 4 millimeter. With an osteotome, here you see the sinus floor that is pushed up. And then you can integrate your implant. This is an oval-shaped implant for a premolar. And with an apical thread, you can gain a lot of primary stability. And you see the bone will perfectly regrow around this implant. So that is how an internal sinus lift works, and you can always combine it with ceramic implants when you lose around 4 to 8 millimeter in the sinus. But what is when we've lost more than 8 millimeter in the sinus? Of course, we would do an external sinus lift. An external sinus lift is always recommended when you lost bone in the direction of the sinus. So in the sinus we have two ways two directions how we can lose bone. So if you lost bone on the sinus side, it's okay to do an external sinus. But sometimes we lose the bone in the oral direction. And this is an indication where you shouldn't do an external sinus lift. Because when you build up the bone into the sinus, you're missing a lot of bone in the oral direction. And this is, in my opinion, it's one of the most difficult indications that we face when we lost a bone in the oral direction and our bone line is almost the same like on the nasal floor. This is really difficult for the patients because not only it is difficult to place an implant in the right position so that we don't have too long crowns, but it's also very difficult to have a removable there. So these patients are really a challenge for everybody of us. And if you do an external sinus lift and you have 3 millimeters of residual bone height, you can combine your sinus lift in a one-stage approach directly with your ceramic implant. If you have lost more and you only have 1 or 2 millimeters of a residual bone height, you should always do a two-stage approach. We at the Swiss Biohealth Clinic, we always do a one-stage approach, but we have found a technique and possibility of stabilizing our implants even if we only have 1 millimeter or no bone in the sinus. I will show you that in a minute. But if you don't have this technique, you should always do it in a two-stage approach. So first you build up your bone in the sinus floor and then you place your implant. The bone graft material that we use for an external sinus lift is always, when it's possible, autologous. It is the gold standard, and when you do ceramic implants, bone grafts, whatever, you should become a little gold digger. So you should know all the techniques of harvesting autologous bone. In the tuber, there are many, many possibilities to do that, and we train that also in the bone augmentation week. And here you see you can basically take autologous bone chips that you harvested through your surgery in every region and use them as a bone graft. That is very good for your patient because the autologous bone is the best bone for your patient. You have no immunological reaction, you don't have any foreign body reaction, and you should really learn and be trained in methods how to collect autologous bone. That is always my most important approach. When I do surgery, I want to collect as much as autologous bone as possible. If you cannot collect it, you should, as a second choice, use allogenic bone, so donator bone. In Switzerland, we are very lucky to use living donor or be able to use living donor bone that is cleaned and sterilized and everything. But still, the immunological reaction can happen, and I always try to use autologous bone, and if I don't have it, I would use allogeneic bone, allograft. Or we also in the sinus have the possibility to just use PRF, but then we always have to combine it with the implant placement because we need a space holder that keeps the periosteum, the Schneiderian membrane, on a distance, like here. This sinus lift was just done with PRF, and then you see the placement of the implant, and the implant has a disc that keeps or holds the sinus Schneiderian membrane on a distance, and then you can add your PRF membranes, and you have a space holder, and basically you can you can put also a little bit autologous bone, but you could also only use PRF in this region when you can combine it with implants. Never do it when you have a two-stage approach, because the PRF membranes will be, they are no space holder, so after 8 days they are gone. So when you use PRF, we recommend to use the low-speed centrifugation concept from Professor Ganati, who's trying really to put PRF on a high scientific level, and he's doing a lot of research. When you just do PRF membranes, you should use 2,400 RPM for 8 minutes. Then you have the best result. It depends a little bit on your machine, but he has recommendations for every machine. You have a special formula for the RCF that you can read and look with your machine. But this would be the machine from Mectron, for example, where you use these guidelines. And if you want to combine your PRF membranes with iPRF, the injectable PRF, you should use 1,200 RPM and spin it for 8 minutes. We inject the iPRF before every surgery in every region because it contains a lot of stem cells and growth factors, and we accelerate the wound healing a lot. This would be the sinus implant with the disc, and I just wanted to show you the surgical approach. So first, or the surgical protocol, first you open your lateral bone window, you insert the PRF membranes, then the PRF membranes will protect your Schneiderian membrane. Then you can drill for your implant, and then you place your ceramic implants and add more PRF membranes, or you add your bone graft. That would basically be the biological approach for external sinus lift. So to sum it up, when do we use an internal sinus lift? When do we use an external sinus lift? So our rules are, when we have a vertical bone height of 5 to 8 millimeter, you can easily do an internal sinus lift. When you have less, let's say 3 to 5 millimeter, it also depends on the quality of the bone, of the residual bone, you would do an external sinus lift, but a one-stage approach immediately with your implant. When you have less than 3 millimeters, let's say 1 to 2 millimeter, and you don't have techniques to immediately stabilize your implant, you would do an external lift, sinus lift, and then you would place your implant on a second stage. And the most difficult defects when we look at our classification are the defects in part 3. When we lost over 8 millimeters and we have a horizontal, vertical, or combined defect, they are really challenging. It would be, for example, this, where we see it was a patient that had a high parodontitis. He just had 1 or 2 millimeter of residual bone around his teeth. I will show you that case in a minute. Sometimes we face defects like this, really only 1 millimeter of bone height, so usually we would need to do a two-stage approach. We have patients that come to us like this, and this patient was really devastated because even her removable didn't really hold, and she's around 50, so she still has a long life to live, and she wanted to be able to chew again. And we made that possible because at the Swiss Biohealth Clinic, we don't work with any removables. Our patients always get fixed prosthesis on fixed implants. So we don't do removables, and we want to have a solution for all the patients. And also for her, we could offer her a solution. And she's more than grateful that she can chew again and that she can really chew. Sometimes we face, like I said, a bone resorption into the sinus area or from the oral part. So this is a really, really challenging defect. Also on the lower jaw, we sometimes face a huge horizontal defect, for example, like this. And these are the really interesting indications and where it becomes challenging. So what do we do with these defects? We want to have a solution for them also. But before, I want to show you another thing that we do, or that what is possible with ceramic implants. So this was a Swiss patient that came to us, and he also was very devastated because everybody told him that he has to remove all the teeth and that he can only have removables, and he's around 45, so he didn't want to accept that solution, and he searched and searched and searched until he came to us, and he said, my only wish is to have a fixed dental prosthesis or something fixed. Of course, we all know the all-of-4 concept, but he knew that titanium was not good for him, and the all-of-4 just works with titanium. So we could offer him a solution and also a very good aesthetic result with ceramic implants, biological approach, and he's one of our most grateful patients because he believed there must be a solution and we could offer it for him. And we could offer it through the invention of the RIP, the RAP, Rebuild Aesthetics Procedure. That is a procedure that helps us to place the implant in a perfect aesthetic position and rebuild the smile of our patients in a biological way, in a perfect aesthetic result. And how does that work? So what we found out is when we want to have a good aesthetic result with ceramic implants, we need to place these implants in a perfect symmetrical position, on a perfect anatomical position. And this was done by Dr. Simon Perry. He is a very, very well-known surgeon in Monaco. And he is known for placing the implants in the perfect parallel way, in the perfect position. And the question is, what is the perfect position for our ceramic implants? And that is also a question that we ask ourselves. Where in the alveolar ridge is the perfect position? So what we did is we measured a lot of 3D scans. We measured every tooth position, and we measured them also in accordance to special anatomical parts, like the incisivus channel. And we measured 3D scans of young people, of old people, of children, of everybody. And we found out that the teeth are in a special relation and distance to each other. There's a special or a mean distance that everybody has and of the teeth. And when you place your implants in this distance, you will have a perfect aesthetic result. And how do you find out these positions, and how do you transfer them into your surgery? Because it is difficult to measure it out, to know where it is. And for that, we found the AIM, the anatomical implantation method. And this is a method that helps you to drill for your implants in a guided way in the surgery, but you're still free because you use the system and you place your implant next to each other, but you don't have to do a lot of planning because you have special distances that represent the anatomical distances that we measured out. And with this system, you can really place your implants parallel in the perfect anatomical position. And I just wanted to show you a quick example of it. And we found out that there are some anatomical laws. And this channel of the nervus incisivus, Alain Simon Perry, Dr. Simon Perry says that God found it for us surgeons. He wanted us to put a stick in it and place the implants in accordance to this channel. And we found out that this is really the truth. When you place your implants parallel to this channel, and these implants are parallel to each other, you will have the perfect aesthetic result. And that is a game changer in implant placement. So here you see an example of our measurements of only one 3D scan. And you see that we always measured also the middle incisors in distance to the channel, and then the lateral incisors, the canines, and we found out middle diameters that we implemented in the AIM system. So this is our, the Excel where we placed all the numbers and where we found out the mean numbers. And here you see a clinical example of how we place front implants. This is a special tool that helps us to place the two front implants in the perfect position to each other and to the channel, the nervus of the nervus incisivus, and then in the perfect parallel way. And that helps really in the surgery to place the implant perfectly. And once you place the implants, you can use this tool with different diameters for different regions. Here, for example, we placed the implant next to the canine in a distance of 7 millimeter. And it helps because you can place it on the implant and place your implant perfectly parallel and in the right distance. Here it is combined with an internal sinus lift. And you see how thin the alveolar ridge is, but still, we don't need to do a lot of bone grafting. We still can just use our ceramic implants. And all these implants and this surgery, and it was the live surgery that we did on the bone augmentation week, gained over 70, a level of over 70 with the ICQ, with the stability level. ICQ is a device, or is the AniCheck from Neobiotech is a device that you can measure. With that, you can measure the implant stability, and it was over 70, which is a really, really good number. So again, still, I haven't explained how we can use or how we can build up this bone on a biological way. So, as we said, when you lost your bone into the sinus, no problem. You can do an external sinus lift. If you lost your bone to the oral side, you can't do an external sinus lift because your implant will be too high, one level too high. So what is the therapy for things like that? Or for defects like that? So when we look into the literature, we see the recommendation of iliac crest autologous. We see the recommendation of allograft bone blocks that are prefabricated and placed in these defects, but you always have to close the tissue, which is really challenging. We see the recommendation of meshes, of titanium meshes that also need to be closed. And we see a lot of problems with these techniques. One problem would be dehiscences. Another problem would be dehiscences and bone resorption of allograft bone blocks. Often we lose over 30% of the bone. Why? Because the tissue is closed over this, over the titanium mesh, for example, and the over allograft. And what does the closed tissue do? It puts pressure on our allograft. Worst case, there's a high resorption. Even worse case, there's a dehiscence. When we look at the scientific research, we see a lot of studies that prove that these techniques have a lot of problems and complications. So we have over 45 of acute morbidities and chronic 1.5%. We have an early dehiscence in titanium meshes of 14.6%. And in every 10th inserted mesh, we have a late dehiscence, which is a lot. And also the soft tissue complications are over 30% of, for example, perforation of the mucosa and the grafted bone, or an infection of the bone block. So we want to have more secure procedures. And what I now want to present to you is the open healing concept of Professor Ganati, because he's facing the same problems that we do and that literature does. And how did he solve it? This is where he started with his open healing concept, so he allowed me to use his pictures. It's a patient's case from Professor Ganati. And back then he used a titanium mesh. But he also had the problem of dehiscences, and he is also a big researcher in PRF, like I told you. So his idea was to just leave the flap open. Why not just have the dehiscence from the beginning, from the start, and just leave the flap open, don't put any pressure on the tissue, but add a lot of PRF and a collagen membrane to it. So it's always important to combine the whole open healing concept with a collagen membrane and PRF. And for the protection of his open side, he used a latex glove and just sutured it over his defect for 1 week. And what he saw in the following is that the tissue grew underneath the titanium mesh. And that is totally natural, because tissue will never grow over a titanium mesh. It just does not like titanium, so that won't happen. But still, when he removed his titanium mesh, he saw that he had granulated tissue underneath it, and that he could keep the contour of his alveolar ridge because he hadn't closed the flap and hadn't put pressure on it. And he could easily place his titanium implant and get a lot of bone from it and get a nice aesthetic result. And that was when he started with the open healing concept. And then he met Dr. Waltz, because he has the problem, he does a lot of tumor reconstructions. And a titanium mesh usually is prefabricated. So you do a 3D scan, you analyze the defect, and the titanium mesh matches this defect. So it's fabricated before you do your surgery. But when he does his tumor resections, he never knows during the surgery how big the tumor is, how big the resection will be. So he always had the problem, he needed a titanium mesh, for example, to reconstruct his defect, but he didn't have one because he first needed to do a 3D scan, he had to do a re-entry of the situation, the patient had to, couldn't eat in that time. It was really difficult. So when he met Dr. Waltz, he explained all his problems to him, and Dr. Waltz, and he invented titanium meshes that you can individually adjust to your defect. So he uses them on a regular basis on his tumorous patients. We have all sizes. And the good thing is you can really adjust them directly in the surgery. You don't have to prefabricate them. And that is how they look. We have different ones. We have single star, double star. And the good thing is that you can kind of make the arms shorter and you can bend them easily. It's titanium grade 4. And you can adjust them to your defect. And when you combine them with the open healing concept of Professor Garnati and allograft or autologous bone, you gain a lot of bone also to the vertical. So that is how it would look. So you can use it for vertical and horizontal bone loss, only with screws, cortical screws. But these meshes can also be combined with implants, with ceramic implants. So when we have a ceramic implant and we don't get primary stability because the defect is too big, we just combine it with a titanium mesh. We stabilize it with a titanium mesh. Also, even 2 or 3 implants can be combined and can be stabilized with these arms that are individualized on the bone and fixed with cortical screws. And I wanted to show you for the end some patients' examples. This was a single BIS that I did. It was a patient that even is a smoker, so she smoked 30 cigarettes a day, but still the open healing concept works. And she had a profound radicular cyst, a vertical and horizontal bone loss, and it was not possible to place an implant. I did not place an implant with this stabilization plate because I wanted to be a little bit more conservative because she was a smoker. So here you see the defect where we started. And that is really a high radical or a profound cyst, and the side walls of the bone were lost, of course. So we only had 1 millimeter of residual bone height. You cannot place an implant immediately. And if you don't place an implant, you lose a lot of bone. And when you have the re-entry, you lost all the bone to the oral side, so you're 1 level too high. So it's not even recommended to place an immediate, to do a sinus lift, an external sinus lift then. And it also does not help you in this situation. She had a big opening to the sinus to insert bone graft, because your bone graft will, even if you place a collagen membrane, you cannot really place it very well. So it was a really challenge to reconstruct this defect. So what I did was I put a collagen membrane and I put my bone graft, but I didn't want to put any pressure from my flap on the bone graft. So I combined it with a titanium single star, a BISS, bone implant stabilization system. You see that here in the surgery. So you can adjust it, you can shorten the arms and fix them with a cortical screw. Then I placed my bone graft, my allograft in this case, because I didn't have enough autologous bone. Then you place a collagen membrane. The collagen membrane basically is a guidance for the tissue, for the granulation of the tissue. And you just keep the flap open, you don't close it. That is a little bit challenging in the beginning because we are used to close everything as surgeons, but with the open healings concept you don't do that. And then you place your PRF membranes above the collagen membrane, and that helps the tissue to granulate over the defect and underneath the titanium mesh in around 1.5 weeks. And for the protection, we use a PTFE membrane. We didn't use, in our protocol, we don't use a glove, but a PTFE membrane. Here you see the pictures that were made during the surgery. And that is how it looked when she came back after 4 months. And here you see the 3D scan after 4 months of this intervention. And you see that underneath this titanium mesh, we have a full reconstruction of the whole alveolar ridge to the oral side, because we didn't have any pressure on our bone graft. So we build up, or I could build up the bone to the oral side. The patient still smoked 10 cigarettes a day at least, but it did not cause any problems. And the bone that I faced when I placed the implant was perfect. It was like when you do a bone graft, you often don't have any blood support in your bone graft because the angiogenesis is not easy on a allograft bone. But when you put your allograft underneath the titanium mesh, you have a perfect vascularization of your bone. And again, I combined the placement of the implant with a little bone graft on the distal part with PRF membranes, and here I used a glove, and I could place the implant in the perfect position. So with that approach, I could do a vertical volume, or I could vertically increase the volume of around 8 millimeters, and also on the horizontal, at least I gained 1 millimeter. So I could preserve the alveolar ridge, the contour of the alveolar ridge. And that's a huge success. And this is another case that Dr. Waltz did. He used a single bis and a double, and that is an approach where he did an external sinus lift, but he did not have a lot of residual bone, so he had to stabilize his implants with the BISS. And I show you the patient's case. So that's how the patient came to us, especially look at the molar sides of the upper jaw on the upper right and upper left. And you see he had an impacted wisdom tooth. That was why he had lost a lot of bone in that region. The oral pictures look quite okay, a lot of metal, but when you look at it in the surgery, it was, he had lost a lot of bone. So what Dr. Waltz did was an external sinus lift. Then he stabilized his implants, his sinus lift implants, with the BISS. He also put a bone plate on the distal arm of the BISS in order to use the shell technique, the bone shell technique, to have a space holder and not get any pressure off the tissue on his bone graft. Then he added allograft. And here he closed it. We would now close it less. We learned from Professor Ganati that we don't have to close it. We can really leave the flap open. And he put a PTFE membrane over the defect. On the other side, he had to stabilize the second implant with the BISS. Also an external sinus lift, and then implant placement with the titanium plates, and also placed a collagen membrane, PRF, and PTFE membrane. Here you see the X-ray after the surgery and after the removal of the titanium mesh. And you see that is after 4 months, that the tissue will always grow underneath the titanium. But look at the width of the alveolar ridge. He could preserve a very high width, and that is the most difficult because you always have pressure from the cheek and the tissue normally. That is how it looked after the removal of the titanium, and after the healing. The patient took blood thinners, that's why it looks a little bit bloody on the middle picture. And after 4 months, the ICQ, so the ANI check, you see it here, was over 80 on these implants. And you remember maybe the clinical photos, we didn't have any bone around these implants. So that is a really, really wonderful result. 82 on this implant. And on the other side, 79, which are really, really good levels. And on the last implant, that was really only having 1 millimeter around, still 81. So here you see the clinical results, and then you place the abutments, or we place the abutments on these implants, and also the gum was healing perfectly. And you could say we have such a huge width of the alveolar ridge that is only possible with the open healing concept. Another case I want to show you where you also can use these stabilization plates is when you have a high periodontal resorption of the bone, but you still want to do immediate implant placement. And that is the case that I just showed you in my lecture before. So when you look at the first and the second molar in the upper left, you see that there is not much bone left. And when you want to place your implant in that position, it is difficult to gain a primary stability. He lost a lot of vertical bone height. If you don't do anything, you also lose a lot of bone, and when you do the re-entry, you will have the problem that the external sinus lift will not build up bone to the oral side. So this is a really challenging situation. So we would love to place implants immediately in order to stabilize our bone and our alveolar ridge. And here you see the intraoral photos of the surgery, and you see that half of the implants were sticking out, and we could stabilize them with, I could stabilize them with the double star, and also placed a bone graft and collagen membrane. And over the healing period, the titanium grew out. This is totally normal and okay. And this picture is after the removal of the titanium. So here I have a short video of the surgery, how it was done. You see the insertion of the allograft, and this was a collagen membrane that we used back then. We used different materials and tried different materials, and now we have a really good protocol of certain collagen membranes that work very well. This one was working very well, but it is very difficult to handle. And this is a PTFE membrane that we used back then. Nowadays we would suture it over the defect and not suture it under the tissue. But back then I did it that way because that's how we started. So we see we are also developing. Still, the case worked out very well, but we know, or we learned a lot about, or through our cases that we did. And this is a cytoplast membrane, which is also really hard to handle. So now we use a different membrane that is much easier to handle. So you see the suturing was not the easiest. This is when the abutments were placed on the implants and they were prepped. We also placed implants in the lower. Here you see them from the side. And you see that I could still place the implant in the perfect prosthetic position, and that the height of the alveolar ridge and the width of the alveolar ridge didn't get lost. And the last case I want to show you is the triple, the BIS triple. So what you can also do with individual titanium meshes, you can build up huge defects. And here we had a huge combined vertical and horizontal defect. You see that here. The patient had lost 2 implants, because back then an external sinus lift was done and the implants were too high, the problem of the bone resorption to the oral side. So here you see the residual bone height. That bone was on the level of the nasal floor. So here it's not helpful to do an external sinus lift. You really need to build up bone to the oral side. And that's what we did with the triple BISS. Here you see the intraoral photos after the surgery, the X-ray. So basically the whole defect was built up and individualized with a titanium mesh. Again, with allograft, collagen membrane, and also the PRF. You see that the titanium is growing out of the defect, but still underneath the titanium we have a granulation of the tissue, and that saves us we don't have any pressure on our bone graft. And here you see the video of the surgery. So the arms were adjusted to the defect and bended. And now you can fill this up with your bone graft, and this bone graft will be vascularized because it is not a block, it is just single pieces, and the vascularization process from the periosteum is much easier. What is important is not to put any pressure from the flap on this. So you just keep your flap open, you add your collagen membrane and the PRF, and then you just put a PTFE membrane for 1.5 weeks, just until the granulation process is done. This is the collagen membrane that we used back then. Was a better membrane, but still difficult to handle, so we have another one now that is really working very well. And you all learn that in the bone augmentation week. So the collagen membrane is always important because it's longer there than our PRF, and it protects our bone graft from the infiltration of epithelial cells. And then it is really important to place a lot of layers of PRF. PRF accelerates the wound healing, and it works as a guideline for our tissue to grow over the defect. So this was done here, and then of course it is important not to put too much pressure, not to close the flap. You want to keep it open, and then you will have a wide alveolar ridge afterwards. So here you see the 3D scan after 4 months, after the surgery, and you see how nice the alveolar ridge grew and was reconstructed. And with a combination of an internal sinus lift, you can immediately place the implants. So we could get a lot of bone. There's a screw that I took out after the X-ray was done. And you see we gained over 5 millimeters in that region. And also here we gained a vertical bone height. And that is enough for our implants to be placed in the perfect position. So these are the photos after 4 months. Again, you see the granulation process underneath the titanium. This is the bone. It was perfectly vascularized, and it was possible to place 4 implants with a stability of over 70 ICQ level in the perfect prosthetic position. And these implants are now stable, and will be the prosthetic supply will be very soon. So here we had a vertical volume increase from 3 to 6 millimeters, and a horizontal increase of over 3 millimeters. That was when the external sinus lift was done. So you see these implants got lost, unfortunately, because they were too high. There was the crown implant ratio was too high, so the implants got lost. And now we have 4 stable implants in a perfect position. So I hope I could transfer the spirit of Switzerland and what we do here a little bit to Las Vegas. Thank you for listening and for your attention. It was a great honor. If you have questions about my lecture, you can contact me via rebekka.hueber@swissbiohealth.com. and I hope you have a wonderful time at the Congress. I hope to be able to travel soon to the US and work with you, and thanks a lot for your attention, and I hope you learn a lot from the other presentations. Goodbye.